Good morning, everyone. It's no longer evening. We are here on an early day on HerniaTalk Tuesdays. My name is Dr. Shirin Towfigh. Welcome to HerniaTalk Live. I am your hernia and laparoscopic surgery specialist. Thank you for following me on Twitter and Instagram at HerniaDoc. Many of you are joining me as a Facebook Live at Dr. Towfigh. And as always, at the end of this session, I'll make sure that you have full access to this episode and all previous episodes of HerniaTalk Live on my YouTube channel. I'm super excited to have Sue Blackwell. She is coming to us from Liverpool, England. She is a hernia patient advocate. I love for you all to hear her story and learn from it and hopefully find your own or be one of your own. She's coming to us from the UK, which is why we're earlier today. You can follow her on Twitter at Sue B, and please provide a warm welcome to Sue. Hi.
Hi, thank you for having me today.
It's evening at your time, kind of midday for us. So I really appreciate you coming on on your evening. I'm sure you've been working all day, and I know you had a lot of meetings before today. But we have a lot of enthusiasm about you because your story is very unique, and what you do and help patients is great. And so I wanted to hear a little bit about your story. We actually met in person.
We did.
At the European Hernia Society meeting. So that was very exciting. And then before then, I think we were just like Twitter mates. Is that right? Mostly on Twitter.
Yeah. So, Twitter is where it's at.
Yeah. So I'm super excited. We're already having people welcoming you on the show. So maybe you can briefly tell us your story and how we came to meet.
Yeah, so obviously I'm Sue. Hi, everyone. So I had inflammatory bowel disease. So I ended up, medication failed, so ended up having a panproctocolectomy and then ileostomy, which obviously I thought at the time was going to be the end of everything, because they tell you surgery cures UC and you'll be fine and happy. And then, so that was it's a long time ago now, 2005. And then I developed my first parastomal hernia.
Oh,
so so I had that repaired in 2007.
Mm-hmm.
And so parastomal hernias they're a thing, aren't they? That's why we're here. But you know, it's kind of, so no, for a lot of us it's part and parcel of having a stoma that you might end up with a parastomal hernia. But I guess at that point I didn't realize what it would lead to. So obviously 2007 was repair number 1. And then in 2017, I had repair number 6.
Oh, wow. Wow. Oh my, Sue, that's horrible.
So I guess, I know, well, that's the thing, because they sort of say, don't we? I mean, I don't know. I say to patients, you know, repair number 1 has probably got at best a 50% success rate, but you don't think what will happen if you're not in the right 50%. You just think, oh yeah, I'm going to have surgery and I'm going to be fixed and it'll all be great. But I wasn't in that 50%. So yeah, all the surgery in between. And then, you know, you mentioned that, you know, we've kind of spoken on Twitter. So I guess with Twitter, I got involved in Twitter. There's a huge amount of colorectal surgeons and hernia specialists on Twitter. And I got talking to people, and then it kind of just spiraled from there. So somebody saw me tweeting about my live tweeting almost all the complications from my last repair, and then invited me to speak at the Association of Coloproctology conference here in the UK. And I did that, and then just from there I've just kind of got really, really involved in kind of parastomal hernia research and spreading the message about it's not just a hernia.
Yes, thank you for that. So you had ulcerative colitis.
Yeah.
So you're cured of your disease after the colon was removed.
Yes.
The problem with ulcerative colitis, besides needing that big of a surgery, is that you're probably on a lot of medications to control the disease. And so you're not having a stoma surgery as if like your tissue is totally normal. You probably had steroids and other medications that prevent healing to try and treat the inflammatory disorder. And then in addition, you need surgery for the ileostomy.
Yeah. Yeah, I think that's potentially part of it, isn't it? Because, quite a few years on steroids, immune suppressants, and then somebody told me once, I don't know how true it is, that sometimes people with IBD have slightly dodgy collagen. I don't know whether that's true, but somebody told me that once. One of my surgeons said that, and I thought maybe there is a bit of truth in that.
Yeah, I'm not sure how much truth there is to that, because it is an inflammatory disorder. However, I wonder if it's dodgy tissue because of all the medications you have to be on to control it. Because I think patients with Crohn's disease, which is kind of the sibling to ulcerative colitis, are both inflammatory bowel disorders. That one, the tissues tend to be pretty normal. You often operate for complications, not for the inflammatory portion of the colon. But it's interesting you had problems with ileostomy. So there's, in my recent post on social media, I talked about the 3 stomas that we deal with. There's ileostomy, which is basically small intestine, which goes through the muscle of your abdominal wall, and then you have your stool coming into a bag. There's colostomy, which is the colon, so the large intestine. So it's a larger hole than the ileostomy going through the muscle, and those have a higher rate of peristomal hernias. And there's a urostomy, which is not common, but in those who have it, they use the small intestine to make a fake bladder. And then that bladder is brought out as a small intestine through a small hole in the abdominal wall. Those tend to have a much lower risk of abdominal hernia. So you're urinating into a bag into your abdominal wall. But either way, the surgeon is causing a hernia, right? It is technically a hernia, but you want the bowel to herniate so that you can empty out. The problem is you can't control what happened, like how big that becomes. Wow, you see, you've had 6 or 7 operations?
Six parastomal hernia repairs, a few more surgeries on top of that, but yeah, 6 parastomal hernia repairs.
So one of the questions we're being asked has to do with your recovery. So how long did it take for you to recover from each operation? Did you have a lot of nausea and bloating and pain? How involved were these operations each time?
So the first repair, it kind of just, because that was just done kind of at the stoma site, so that was a relatively straightforward recovery. The second one, I unfortunately let them resite the stoma, so it was a full midline laparotomy, and it was resited, which I now know is not the right thing to be doing.
Yeah, there's been a lot of, we've changed a lot of our recommendations over the times.
Yeah. So we did that. So obviously that was a full open incision. So that took sort of 3 months to recover from. The other ones are a mix of like laparoscopic and open, and maybe I'm just a bit strange. I found the laparoscopic ones much harder to recover from. The recovery seemed longer. But then repair number 6, I probably never fully recovered because I had a lot of complications, and then I ended up back in theatre 15 months later as an emergency.
Oh, for what purpose?
So I had lots and lots of like subclinical obstructions over those 15 months. I was in that hospital, and I managed to put myself in acute kidney injury twice in 10 days. So they just went, okay, no, we're going to go in and unstick everything, because everything was quite stuck together.
So this person who's asking the question, she's still in pain at 4 weeks from a complex abdominal wall reconstruction. Did yours take longer than 4 weeks sometimes to recover?
I think 4 weeks is really early. I think you have to give it time, probably maybe 3 months or so, especially when you use the word mesh. If you're using mesh, and I have no issues with mesh because I haven't had any problems, but you guys use sutures or tacks to hold the mesh in, and they are the most painful bit, the tacks. Even the absorbable ones, they you feel every little tack for a long time. So yeah, 4 weeks in, that's like, that's early days.
So let's talk about mesh. So in general, incisional hernias or hernias after any operation don't heal well unless there's something to help with the closure. So just closing the hole doesn't work, it just falls apart. That's where mesh comes into play. The European data shows about 50 to 60% hernia recurrence if you don't use mesh. Using mesh is not that much better. I think it's like 25%, but it's less than half. But with peristomals, it's such a unique situation because it's not technically a clean operation because you're dealing with open intestine, and you don't want mesh to erode. So you don't want the mesh to get infected, whereas you're dealing with open intestine, and you don't want the mesh to erode into the intestines. So have you had like different types of mesh or absorbable mesh, or what do they do for you?
I've had 6 different types of mesh. So I have had the when the stoma was resited, they put a 30 by 30 bit of polypropylene in on the right hand side, which has caused no problems. There's quite a large, I think, incisional hernia now because the surgeons had to go through that mesh twice.
Yes.
With repair number 6 and with the emergency surgery. But yeah, so I've had different meshes from different companies. So a lot of them, the biological stuff, but you know, I guess, well, they sort of done their job. The hernia has recurred, but you kind of knew it would. But mesh wise, I haven't had any issues. And I know some people do have problems with mesh, but I always say to people, you know, with a parastomal hernia, if you're going to repair it without mesh, it is going to recur. 100%, it will come back.
Bigger.
And I guess it just depends how long you're going to get, because you might get 10 years, but you might only get 10 months.
Yeah.
It's very much kind of what sort of a risk are you willing to take?
And what do you know about the current standard for peristomal hernias? Is there any use for, do you guys have like hybrid meshes there?
I think we do, yes.
Yeah. Do you know if there's a trend towards using less mesh or more biologic or not?
Not that I'm aware of, but that's something that we're looking at in a international parastomal hernia treatment study that I'm helping to run with Tom Pinkney, so PROPHA, which is going to be looking at patient-reported outcomes after parastomal hernia treatment. So we're looking at operative and non-operative, but part of that is obviously we'll be gathering all the data on how the surgery was done and what mesh they used and, you know, where the mesh was placed. So that will give us loads of data. So I think that's going to be really helpful because we'll have a huge data set from across the world. So we can look and say, actually, do you know what? It looks like this mesh in this plane with this operative technique is the better one for preventing recurrence.
This is fascinating. So you had a normal day job.
I have a normal day job, yeah.
And then what happened was you started communicating with the world about your issues, and now you're linked with major colorectal surgeons in the UK.
So myself and Tom are chief investigators on PROPHA, and I actually in January started my PhD, and I'm doing that on parastomal hernia and shared decision making.
That's fantastic.
Alongside the day job.
I'm not sure there are many people like you though. Is that true? Do you have colleagues around the world that you connect with?
There are other people like me. You met Nicola Dames. You met her in Denver.
Yes,
last week. Great. Yes, so Nicola does similar, and there's other people here in the UK. I don't know. I guess I never realized before that patients could be this involved in research and changing outcomes for other patients, but I don't know, it kind of puts, 6 parastomal hernia repairs and all the sort of stuff that goes with it. It's not very pleasant. And it's one of those sort of things, if you sat and, I don't know, looked at it, actually the different, the impact it has had on my life, you'll probably sit in a corner and cry. But by doing all of this, I can put all of the bad stuff to use and help other people so that other Sues don't have to go through it.
That's so lovely. So you're actively involved in research, which is fantastic. What do you say to people that their marriages are disrupted by all these operations, their work is unhappy because they're taking so much time off? How did you have to deal with the social aspects of all these complications? Because peristomal hernia, of all the hernia repairs, the worst outcomes are from the peristomal hernias and the denervation injuries, the ones where you actually have a bulging from nerve injury. So how do you talk to patients about how you dealt with it?
Well, I guess I was lucky. I was single, so I didn't have to think of anybody but me. Although again, there's a downside, because then there isn't anybody to kind of help you with things. You just have to get on with it. But it had a huge impact on, like work and finances, and it's really, really difficult. And that's why I sort of say to people, really, really think hard about whether you want to have surgery, because if it goes well, that's great, and you'll get a really good quality of life back and be able to do what you want to do. But if it doesn't go well, then you actually can't imagine right now how much of an impact it has on your quality of life. And it was something actually I hadn't thought as much about, because before I moved to Liverpool, I lived in London, and I was in the civil service.
Mm-hmm.
So and we had great sick pay, and I know sick pay in America and all of that is just like virtually, you don't have much annual leave, do you, or sickness and stuff. Yeah. So in the civil service, I got 6 months full pay and 6 months half pay.
Wow.
So I had a lot of time out, but it was fine because I got paid properly, didn't have any worries about paying bills. And then when I moved here and I started working for a private sector company, and my sick pay was 10 days. And then it's like, okay, so, and the government sick pay is something like £93 a week. So I'm not quite sure what that is in dollars. It's not very much. The exchange rate is not great, is it? So probably only maybe about $120, $130 a week.
Yeah.
And that's what the government give you to live on. So it was
nuts.
So it was really difficult, because you've got no choice but to go into hospital, but then you're left like, well, I don't know how I'm going to pay the bills, and then you have to ring up the bank and say, I can't afford to pay this month, and I can't do this, and then you can't go out anywhere because you haven't got any money.
Yeah, there's a comment about that's a great point, because if you have surgery go bad, it can ruin so many different aspects of your life. So do you also let me ask you this. So you do your research with the colorectal surgeons and the different society you're involved in, hernia societies and so on, and then you work one-on-one with patients as well?
Not necessarily one-on-one, but I'm in quite a lot of Facebook groups, and I try to give advice that way. I think sometimes it's very difficult. That's why I do a lot with the surgeons, because sometimes I think surgeons are more receptive to hearing about things, because if I stand up in front of them and they see an actual person who's had like 6 parastomal hernia repairs, and I tell them about all the bad things, and then I show them pictures of my CT scans, and then they're like, oh, okay, yeah. It kind of puts it more into perspective for them. And then I know that when they next see another patient like me, they'll think about, oh, actually, what am I doing? Is this the right thing? But I do try my best to sort of help other patients.
That's nice. It does humanize the situation more than usual. So do you talk with patients that have not had peristomal hernias, that just have had abdominal wall hernia surgeries?
Online, yeah. But I think a lot of the people that I've spoken to have had parastomal, but also they've had they've needed an abdominal wall repair as well as a parastomal hernia.
So one question is, I've had umbilical and ventral hernia repair with absorbable mesh, and subsequently had mesh removal. My urologist is now recommending cystoscopy in conjunction with laparotomy for adhesion removal. What risks are associated with this procedure following a history like mine? What can I do research to better advocate for myself? I'll answer the first part. I'll have you answer the second part. So the first part is, now that you've had mesh removal and they want to do adhesion removal. So I'm assuming your hernia hasn't come back, but we prefer to do adhesiolysis or adhesion removal laparoscopically, because the risk of having more adhesions is slightly less, but it's an advanced procedure. So if you have a surgeon who can do these laparoscopically, and it can be a laparoscopy, that's usually a better total outcome. But what can this person do or research to better advocate for themselves, Sue?
I think I would say, go online and just go onto Google and put, search for surgeons that are doing that surgery wherever you are. I don't know whether the person's in the US or the UK, But you know, go online and see who the people are that are sort of leaders in their field, and see if there's anybody near you. But also reach out to them and say, you know, I live here, and it might be, you know, 600 miles from you, but you know, is there somebody nearer to me that you would recommend? I do find that people are always quite, you know, keen to help people and to recommend somebody else. But it's a lot about going online, looking to see who the best person might be, but also ask other patients what are the questions that you should be asking. Because I think that's the thing, as a patient, you don't always know the questions that you should ask. So maybe, you know, if you talk to others who've had similar surgery and say, right, well, okay, you know, what were your outcomes? Did you have any complications? What do you wish you'd been told before your surgery? Then you've got a good list of questions when you do find a surgeon to say, okay, look, these are my questions. And if you don't answer them, you know, if you can't help me, you know, can't kind of give me answers that will make me think, okay, yeah, right, this is the right decision, to then, you know, find somebody else. It's your life, you know, you are putting your life in somebody else's hands. So you need to feel confident that, you know, that you trust what they're doing. But also I think you need somebody that you can have a rapport with and that you get on with. That's just as important as the surgical skills, I think.
That's a good point. Do you find the Facebook groups to be helpful for patients?
Yes and no. They can be helpful, but I think they can also sometimes be, I don't know, negative isn't the word, but I think sometimes with the best will in the world, because people are giving their own personal lived experience, you can't tell them that what they're saying is wrong, because that's their lived experience. But when I see people in Facebook groups who say to somebody, you mustn't have mesh, do not have mesh, and it's like, well, okay, you know, you've had a bad experience and I get that, but for every one person that has, there's however many that haven't. But by you telling this person, don't do this, if they listen to you and make that decision, that could very well be the very worst decision for them.
Yes.
So I think there's a balance on Facebook.
Yeah, I have a patient that absolutely did not want mesh, went to another surgeon and had a non-mesh repair, and now they're miserable because they're in chronic pain. They're basically tearing apart the repair because they should have had a mesh-based repair, and now they're pissed off at the surgeon for this kind of bad outcome. It's a give and take, you know. You, as a surgeon, you try and explain. And some patients I just wouldn't offer non-mesh because it's the wrong operation, and I know that they're going to have more complications, more tearing, more pain, and a bigger problem if they do choose non-mesh. So there's a lot of, I know the UK is similar to the US, and that there's a lot of anti-mesh sentiment, and patients go on Facebook or Google, and literally the last patient I saw this morning said, I parked my car across the street, and as I was turning off the car, the radio was giving a advertisement about, you know, have you had mesh? Have you been injured by mesh? Call us to sue. And he's like, I don't know, should I take it as a sign? So, you know, there's a lot of that going in the US. I think there may be as well in the UK. And it takes a lot of time for us surgeons to help educate our patients about, yes, this is a good option. Is a non-mesh? No, definitely you should not be doing a non-mesh option. Question. So the question is this. So have you had 6 meshes total, or were meshes removed and replaced when you had these multiple operations?
Well, some of them were sort of absorbable meshes, so they kind of done their thing and absorbed, but I guess there were some, I know in repair number 6, he did have to he took out the old mesh to put in a new one.
Okay.
But the meshes, they weren't taken out because there was a problem with the mesh. They were just, it was either had done its thing or wasn't doing what it needed to do.
Sure. Yeah, sometimes we remove mesh if it's in the way of a good repair, because mesh on mesh doesn't work very well.
No.
The mesh needs to stick to something that it can grow into, and other implants don't do that. So you need to make space for the new meshes. Okay, another question. This is a long one. I had robotic surgery 3 weeks ago. I had 3 hernias, one umbilical, one at the bottom where my uterus was coming through. So that's a suprapubic, and one on top of my liver on top with my liver coming through. So that's probably like a subcostal. Also, I had my lower organs stuck to my abdomen wall that were cut off of it and placed back where they belong. So it sounds like adhesions were removed. They also used sutures to close my fascia from top and bottom, and a large mesh to the sides of my whole abdomen placed inside, which sometimes you have to do for these really large ones. The pain was intense, and I still have some pain and tightness, and I have to eat small meals because of any bloating causing pain and lots of pressure. Do you get that? Do you feel like eating promotes any stiffness or pain or pressure in the belly? Okay.
No, not anymore. I don't think I've ever had that.
Mm. Well, I think she had too tight of a repair, and I have to eat small meals because any bloating causes pain and lots of pressure. Will this ever go away, or will I always have this pressure because the size of mesh placed inside me? My doctor said I never have to worry about a hernia again because of the closure they did in the size of the mesh. So I'll just give my 2 cents on this. The role of fixing an abdominal wall is to restore a functional abdominal wall. It's not to make you nice and tight. In fact, tightness is perceived as being painful. And if you're too tight, that's not a good thing because you can't bend to tie your shoelaces. You can't lean forward to brush your teeth even. Some people, it's that so tight. So it affects your quality of life. And if your abdominal wall is not allowed to expand with a cough or a meal, then that's too tight of a repair. So, and all meshes shrink. So if you put a mesh in, it'll shrink between 10 and 25%, depending on the type of mesh. So you don't want to make it the original repair type because then once it shrinks, it'll be even tighter. So it sounds like you may have a tight repair. The reason why we don't like tightness is the same reason we don't like tight clothing, it'll tear. So the mesh sounds like it's preventing the tear, but instead you have a tight repair. There's very little to do besides redoing the repair. So I would let time kind of help with that one. Next one, this is for you. I'm really worried about complications of having abdominal mesh removed. I have 3 young children to take care of. Would you advise against having mesh removed? What have you heard about people's stories with mesh removal?
I've only heard a few because for abdominal mesh, I've not heard many people like having it removed unless it's being replaced with something else.
Yes.
So obviously the vaginal mesh, you know, there's a lot of stories about that being removed, and I know that's very specialized, but I don't know that I guess for the person asking the question, it would be also what are the symptoms that you're having from, you know, what are the symptoms that you're currently having, and you know, for needing, you know, for thinking about having the mesh removed, because you know you might want to have a good conversation with the surgeon about what the potential, you know, risks and complications will be post-operatively, because it may be on balance it's better to not go in. I don't know. I sometimes I think it's better to try and do all you can to live with some symptoms rather than just go in and take mesh out or operate, because I don't know, you can only I always think you can really only go into somebody's abdomen so many times before it gets to the point where it's like, yeah, no, you know.
This is very true. This is very true. And I feel that just wanting the mesh removed is not a good idea because there are risks with it. And the second is the risk, whatever the symptoms are, need to be worth it, because you, like you said, any operation has more than 0% risk of going wrong, and it can have devastating effects in your life. And there's plenty of people who said, if I only had known, I would never have chosen to do X, Y, and Z. So that's very true. So let's talk about, okay, there's a question about mesh shrinking. Yes, all mesh shrink. The biologic meshes stretch, the synthetic meshes shrink, so even proceed mesh. All right, another question coming up. How should patients navigate all the conflicting information provided by different providers? That's a good one. Without offending them and therefore being dismissed as a difficult patient. For example, my dietitian recommends a carnivore diet and my GI doc recommends plant-based diet. Okay. But you know, besides the diet issue, you must see that a lot, trying to help patients navigate the system so that they don't put off their doctors, right? Because we're all humans, we have egos, and some people take things more personally than others, and so on. But how do you teach patients to navigate the system and figure out conflicting information and maybe go back to the first surgeon and say, well, the other surgeon said this? How does that work out?
I think it's about making sure that patients are aware of, as I said before, the questions to ask, and when they've asked the questions and they've got the answers, whether it's from Dr. 1 or Dr. 2 or whoever they see, is to then go away and think about it and think, well, okay, so these are the questions that I asked these two people. These are the responses they've given. This is me, and this is who I am. This is my lifestyle. These are all the other factors that I need to think about. And, you know, which person here is giving, you know, do I fit better with, and what are they saying? And then if you think, oh, actually, and you could go back to them and say, well, can you just clarify this or clarify that? But also, I think as well, it's, you know, maybe look online, and there's a lot of research out there, and we're not very good at sharing it with patients, but you can contact people. So I'm sure that you'd be more than happy if somebody, you know, if I was to email you as a patient and say, oh, I've seen this paper that you presented, you know, would I be able to see a copy? Because then you can look at things for yourself. And I think we need to do more about empowering patients to actually, you know, take more of a role in their own healthcare, and looking at what's out there and looking at the research and saying, okay, because I think you should be able to go along and say, hi, right, okay, I've read this paper and I think there's some really good, I think this is a really good technique, and you know, I would like you to consider this. Do you do this? And if you don't, could you refer me on to somebody that can do this? Because I think that this would be better for me. I think we need to be a bit rather, I don't know, historically, doctors have always been up on a pedestal, haven't they? You know, the doctor says, we'll do this. You don't need to worry. But I think now is the time for us to say, actually, you are very well qualified. You know what you're doing, and I'm the patient, but I want to be able to have a say as well.
That's such a good point. And I feel that, well, there's a great book by a former patient of mine, Martine Ehrenclou, named The Take Charge Patient. I used to give it away as Christmas presents because it's so well written. It's written with a patient in mind, and it tells you all the tips and tricks on how to get the best care and navigate the healthcare system. You know, come prepared, have questions, but also don't sound like uppity or argumentative, or how to get appointments. What if they don't give you an appointment for 6 months? So there's how do you communicate a follow-up with the doctor? So it's a great book. It's called The Take Charge Patient, and it's written in a way where it's very respectful for the patient, but also for the doctor, and teaches you all the tricks that I know how to get in. I always tell my patients, call Dr. So-and-so. If you can't get in, let me know. I'll figure, I'll do it. I have a family member right now who's a different country that I'm trying to navigate their care from distance, but you got to do it in their tricks. There are a lot of tricks, basically.
Yeah, but I think that's the thing, isn't it? Different countries have different healthcare systems. So in the UK, I could look up a surgeon and say, oh, they look like the right person.
Yes.
We are allowed to, you can choose the hospital that you go to, but you can't really choose the surgeon. So the referral could go to the hospital, but that surgeon might not pick it up. Whereas I think, you know, because obviously we've got the National Health Service, so it's all paid for, it's free at the point of use. Whereas yours is, you know, insurance based, and you can do it in the States, it's kind of an outsider looking in, you can do a lot more kind of shopping around. And you could go and see 3 or 4 different, you know, hernia surgeons until you found the one that had the technical skills, but also that you got on with. Whereas here, it's not quite the same here.
I would love to know your opinion of that, because often during these Hernia Talk live sessions, I say, listen, for those of you in the United States, take advantage of our healthcare opportunities. You can go to any doctor you want at any time. Now, some of them may cost you more, but you're not limited to like this one doctor 5 months from now. There are countries that are very socialist in their medical care, and it's very kind of difficult to penetrate that system. We don't have that difficulty. You can fly to New York right now to see a doctor, or Florida or Texas, And many of them will be even covered by insurance completely. So it's just a matter of seeking the right surgeon. So if you see one doctor, you don't like them, switch. You can totally do that. Whereas in the UK, I have a lot of patients that seek my opinion and expertise for them. And you do have a two-tier system. You have the NHS, right, which is socialized healthcare. Everyone has access to that. Is that correct?
That's correct, yeah.
But it's somewhat categorized based on urgency and
yeah.
And then you do also have a separate private system. Is that correct?
That's correct, yeah. If you've got private health insurance.
And how is that? Is that more like the US system?
I think so, yeah. I mean, obviously, I can't get private health insurance because they would exclude any pre-existing conditions. So for me, probably most of anything. And if you think back to having had UC and being on immune suppressants, I suppose if you ever got any kind of cancer, they'd say, well, that was because of, the drugs that you had 20 years ago. It's all a bit, but I think, if you have private health, I've seen a consultant once privately because I didn't want to wait the 7 weeks it was going to take on the NHS, which to be fair, isn't that long a wait at the time. It can be months, but it was easier just to pay and go in and see them and then carry on the NHS. But we can do that. You can actually go and see somebody privately. But I spoke to somebody recently on email and they said, oh no, my only option now is to go to the States. And I was like, well, there's some very good surgeons in the UK that, you can speak to. You don't have to go to America.
Yes.
So and I gave them some names of some people. I was like, look, here's 3 people that I know that are very, very good, but they're also very good at talking to patients. And I think that's perhaps more what this person needed rather than anything. Right. But I just thought, oh no, I can't, as nice as you and some of the others in the States that I've met are, I'd hate to think that somebody thought that was their only option, that they had to spend all that money to fly from the UK to the US to get help when there are people here that will do the same.
I agree. And I have multiple patients in the UK. So a lot of the surgeons that I also know. And so I'm like, no, go to this person, I'll contact them for you and so on. Some are doing it through the NHS and others not. But yeah, there are opportunities to be able to do it. I feel that you just have to be your own advocate. No one's going to care about you except yourself better than yourself. Tell me a little bit about this concept for peristomal hernias, which is preventive. So because the rate of recurrence can be in the 30, 40, 60, 75% rate, very, very high numbers, unacceptably high. There's some discussion about preventing the hernia from starting in the beginning by putting in some type of mesh, whether biologic or permanent, at the time of the stoma placement. Is that something that you see is now happening in the UK?
I think it's happening in some places. There's been a couple of, quite a while ago now, there were a couple of clinical trials that looked at it, but they never actually properly reported. But it's something that some people do. And I think at the moment in the UK, they sort of said if you were going to use prophylactic mesh at stoma formation, then you had to also enroll your patients into the CIPHER study that Neil Smart has been running, which is looking at the incident of parastomal hernia. So that's taking people from index surgery and then following them up to see whether they develop a parastomal hernia. So I think that made sense to say, okay, if you're putting in prophylactic mesh, then you need to be part of CIPHER. So that's finished recruiting now, but they're doing the follow-up. But
yeah, the CIPHER study, that's really great.
Yeah.
To have that ability to force people to go into those studies, because we do need that information. Okay, next question. If you had a ventral hernia mesh removed with no tissue repair because scar tissue was sufficient to prevent recurrence, not true, by the way, should not you avoid a future laparotomy whenever possible because it will surely result in a new hernia? So yeah, the scar tissue is never adequate to prevent recurrence. However, if we remove mesh and there's no hernia to repair at the time, we usually don't prophylactically repair anything, especially if the mesh was removed for pain, because you don't want to add. You want to remove the source of the pain potentially, but then don't add another source and then not make the patient better. But there is still a very high risk that that hernia will recur because scar tissue is never adequate for hernia recurrence.
Is that partly then, you've got that thing about, I'm trying to do it with my fingers, but like the short bite closure or long bite closure.
Yeah.
So I think that's quite interesting. When I've seen people sort of demonstrate that with like, perforated paper and a ring binder, and it's like the little holes or the big holes, and it's like, look which one's stronger. So don't know, does that have a big impact on recurrence?
Very much. So yeah, there's a great, I've retweeted that picture at least twice because it's such a great, our friend from Turkey, Hakan Gok, is the one that actually posted it.
Oh yeah.
It's a great visual. He's part of the European Hernia Society. I think he's in the leadership now. Yeah. So what the thought is that if you're closing, I mean, listen, it's the same as tailoring clothing, right? If you're closing a hole, let's say you have either a hernia or more importantly, like you had surgery, like you had your surgery. If once you had your initial colon removal surgery, they had to close the laparoscopic scar, the midline abdominal wall muscles. It used to be they would teach us you have to take big bites of the muscles to kind of cinch everything together. Okay, that doesn't work because the bigger the bite, the tighter the repair, and the tighter the repair, the more likely for it to tear. Now you have big tears, which is what we call incisional hernia or Swiss cheese hernia. So the new trial results from the European group was the stitch trial, or it's what we call the short stitch trial, which is instead of taking big bites, you take a lot of small little bites. And so you can compare it to trying to tear paper out of a 3-ring binder. It's pretty easy to tear. Or tear paper from a spiral, those like tight spirals, much more difficult to tear. And so the hope is that more closures are done like a tight spiral as opposed to a 3-ring binder. Say like the clothing you're wearing right now, Sue, there's not big gaps in the suture, there's like really small ones and it doesn't tear that way. So I don't understand why we do surgery different than when we repair clothes. Like, I don't get that. Why are people not thinking?
Yeah, but it's some of that because, I don't know, historically, maybe, I don't know about the States, but in the UK, a lot of the time it's always been said that like closures when the surgeon goes, and sorry to any surgeons I know that are watching, so closures when the surgeon goes to get a cup of coffee and they just let, the trainees do the closure. So it's like, maybe that's why it was always big bites, because it's like, come on, hurry up, and, let's not take the time. And because I don't know, I guess maybe as a surgeon, some people have historically looked at it and gone, but the most important part is what we're doing inside the abdomen, and like closing is just like we've got to, just as much as you've just got to open, you've just got to close as quickly as you've opened and ship the person out and get the next one in. And
yeah, unfortunately that's true. That joke, I've heard it multiple times. Surgery is coffee time. Surgical closing is coffee time, which means the boss, because surgery is very like a hierarchy. It's like the military. The boss, the attending surgeon is like, all right, guys, close up. I'll see you at the next patient. And you have a medical student or a resident or something closing. Now, I don't do that. I'm very involved till the patient's actually awake. So I don't leave the room until the patient's awake from surgery. But it's very common for the closure to be kind of not considered the important part of the operation. Like your surgery, they took out the whole colon. What's the closure? Staple, 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 And so in my mind, and I may be oversimplifying this, but if I see someone who's had a messy or ugly closure, it reflects to me on the daintiness in which they did the original operation. If I sit in someone's car and it's dirty and it's got food like particles from 2 months ago in the crevices, and then it's a dirty car, I'm going to judge them that they're probably not a very clean or exact person in their real life. That may or may not be true, but that's just kind of like the way you judge people. And that's how I judge people from their closures. If they don't care enough to close what you as a patient are going to see, then it's possible they're not even carrying enough on the inside as much as they should. I don't know.
Yeah.
Maybe
No, I think that's the thing, isn't it? For a lot of patients, what the scar looks like is really important.
Yeah.
And if you've kind of got quite a rushed, messy closure almost, that the scar and the physical appearance, makes a huge impact for patients. And I know some people really struggle because they've got a scar, it's not very neat, and especially if they've had an infection post-op and some of it's opened up a bit. And that, I think the psychological impact of what your body now looks like is kind of as big as the impact of the rest of the surgery, what you might have had removed.
Yeah, people get very depressed by it because they see it every day. And the infection's an issue. Colostomy scars, especially if you are lucky enough to be able to have that colostomy or ileostomy closed and taken down, that scar can be at risk for infection and kind of heal very ugly. Or
because obviously I had mine moved, so and they were sort of like, oh, it's Sue, she'll get an infection, so they sewed it up. It was really badly done. It was really loose, but they were expecting it to get infected, so they just did like almost like a botch job. I would just stitch it up like this because they were like, it'll get infected and we'll just have to cut the stitches out, and it didn't get infected and it healed. But obviously there's quite a dip now. It's a bit sort of like that. So if they'd taken more time or done it another way, so now really there is no way to move the stoma back because of the scar from the previous stoma site.
Is that
they could do, but it would be either really low down or like really high up.
So it's separate scar. They wouldn't go through the same scar.
No, but I think because it goes to, there is quite an indent. So I think if you tried to put a stoma there now, you wouldn't get a bag to stick properly at all, because it just wouldn't, because it's in such a crease. Yeah.
There's a lovely man who I worked with who has a great website and for stomas, and he also, I think, sells a whole variety of, it's like a chat group, and he also sells a variety of stoma appliances and so on. It's a whole like niche, people that need stomas and have stomas.
I know there's a lot of us out there just quietly getting on with things without. I think the thing is, a stoma, and obviously then parastomal hernias and stuff like that, is something that you never really think about until it happens to you. I don't think people talk about the stoma stigma, but I don't think anybody that hasn't got a stoma has ever thought about a stoma. I know I didn't beforehand. I don't think I even knew what one. I don't think I knew what one was. I didn't have any kind of views, negative or positive, about it, because I'd never met anyone with one. So it wasn't a condition that had ever, I don't know, crossed my radar. It's like, you don't think about other, everybody's heard of cancer. Most people know somebody that has had cancer. So cancer everybody knows about, but other things, there's lots of other diseases out there that you'd never even think about. And I think stoma is kind of one of those that until it affects you or somebody, you don't think about that.
Yeah, that's so true. And there's a lot of stigma with stomas. And I feel that a lot of patients, if you tell them they may need a stoma, they feel like their whole life has ended. Like, how are they ever going to be able to deal with that? And they get very depressed after surgery. And yet there are people that need permanent stomas, like your situation, and there are even children that need it. And I don't know, there's like TikTok and Instagram accounts of these people. They're very open about it. They like wear a bikini with their stoma, and it's kind of fascinating to me, because back in the day that was not the case. So
my day job, I work for what we call a dispensing appliance contractor. So we're basically a company that we dispense stoma and urology products. So that's what I do in the daytime, do marketing for that. But one of our customers, she's on Twitter, you might have seen her, she's called Jessica, she's 7, she's got a colostomy, she's Jessica's Stoma Journey on Twitter, and I think she's on Instagram as well. But with her mum, so they tweet and blog all the time about her having a stoma, and she's so open about it, and she's out there, she raises lots of money to provide stoma bears for other children that are having surgery. But she's completely like, I've got a stoma. What
I have a stoma bear.
Have you?
It's the cutest thing. So I have a stoma bear, and my mom's dog plays with it. And I had a picture, I think I posted it or something. My friends were like, only you would have a toy for your dog that has a stoma. But they're cute. They're very, very cute. And there's so much, there's so much appliances and tricks, and there's a whole, like, we had to learn it as a resident. I was very fascinated. I like wound care, so I was very fascinated with all the different appliances that the wound care nurses and stoma nurses know how to do. But it's a very unique population of patients, and the peristomal hernias are a huge negative in those.
As I think that's the thing, because you need to give patients sort of as much information as possible when they're having stoma surgery, but if you tell them too much, you probably would put a lot of people off having a stoma, because as you said right at the start, a stoma, and I say this to people in it because people think that they've done something wrong to develop a parastomal hernia. And they say, oh, but I followed all the rules, I didn't lift this, I didn't lift that. And I said, well, did you cough or sneeze? And everyone's like, oh, obviously, yeah. It's like, well then, coughing and sneezing is as risky as lifting 80 kilograms of something, because if you lift, I always say to people, if you lift things, you lift properly, because you're trying to protect your back, so it's controlled. Whereas when you cough and sneeze, you just do it, and it's that raised, isn't it, an intra-abdominal pressure that has the problem, and people blame themselves. So it's very difficult, and it's like, no, but I think we need to be more aware of saying to patients, no, a stoma is a man-made hernia, because it is a hole in your abdominal wall, and you can't bring the stoma out without making the hole. And it just depends, does the hole stay 3 finger widths like they want it to be, or does it get bigger?
Yeah, that's so true. That's exactly what it is, a man-made hernia. And yet at the same time, there are people that I've offered stoma reversals, and they're like, nope, I'm good. Like, I've learned to live with this. It's comfortable. I don't want to deal with whatever the reason was why they had a stoma. Let's say it was massive diarrhea or something. They don't want to deal with that anymore. They're happy with the way it's been controlled. But yeah, so there's a great study, I think in 2006-ish, maybe wrong, that showed exactly what you said. Coughing is a huge abdominal pressure generator, and sneezing, you can't even control it, right? Out of your control. Whereas exercise does not usually increase your abdominal pressure. Lifting weights does not really increase your abdominal pressure. And if anything, you're engaging your muscles to prevent your back from getting injured and so on. Straining is a big one, but if you have a colostomy or ileostomy, you're not straining, because the stool just comes right out through the bag. So that's one thing that like constipation is not an issue for those. But people with enlarged prostates will strain to urinate, maybe. But yeah, all those little, like smoking, right? Use of nicotine in any way. We have a lot of marijuana smokers in California. They cough all the time from the marijuana smoking. All those are risks to peristomal hernias. So prevention is key.
And I think telling people about, exercise and doing core exercises and things like that, because I know there's still a lot of stoma nurses out there that I think put the fear of God into patients by telling them, oh, you have to be careful about exercising because you might get a hernia, and there isn't any evidence.
No evidence.
And it's like you need to, you need to get out there and exercise and work, strengthen your core as much as you can and do as much as you can to help.
Yeah, all stomas are placed through the rectus muscle, which is your 6-pack. So if you can strengthen that 6-pack, you're going to strengthen the hole around that stoma. So exercise is great, especially for stomas, right? Yeah.
Well, that's why prehab is is important now, isn't it, as well? You know, you get, especially if your surgery is planned, you can carry, you know, you can have some kind of prehab beforehand and try and get, you know, fitter and healthier for surgery, and then hopefully carry that on, because I think that that's a thing that, you know, you've got enhanced recovery, and then you're in hospital and people are getting you up and moving you about, and then people go home and they sit on the sofa and watch daytime TV.
Yeah.
Because and then other people say to them, oh, you need to rest, and it's like, well, actually you need some rest, obviously, to recover, but you need to get moving a little bit more every day.
Yeah. So how do patients interact with you? Is it mostly through Twitter?
Mainly Twitter, yeah, and then obviously when I'm in Facebook groups too.
Yeah, that's really lovely. I love that we can have an international discussion, and there are plenty of people. Do you get a lot of people outside the UK that reach out to you?
Sometimes, yeah. I mean, I think that's why Twitter's good, because people are from everywhere, and you get to, you know, meet people from across the world. But I think, you know, it has been great because, you know, obviously we spoke on Twitter, and then we met at EHS, and and at EHS there were so many people that were like to me. I went to the toilet one time and somebody went, "Oh, I know you from Twitter." I was like, "Hi, yeah, that's me." But people do, they get to know you from things like that. And but it's good that, I think, in a way, Twitter kind of, it breaks down the barriers, I think, between surgeons and patients, because you can have some really, really good discussions on clinical subjects, and be able to give the patient's point of view, because everybody's just about equal on Twitter, really. You can butt into any conversation and say, well, actually, as a patient, I think you should look at X and Y. So
yeah, that's totally true. Yeah, and you're very funny on Twitter. You have a great personality, a fun personality. And how I use Twitter often is anytime I go to a meeting, I live tweet the meeting. So when I'm with you guys in Manchester in was it October? I'll be live tweeting then too. So that's kind of my research to do more.
But that's good for patients, isn't it? Because, you know, you've got the European hernia, British hernia, and then you've got American hernia, and all the different colorectal societies as well. And they all have conferences. So as a patient, you can follow the conferences on Twitter, and you can find out what's going on there and then. You know, the cutting edge research that you might not be able to read in the journal because you don't have access, but you can read about it on Twitter and see who it is that's doing it. And you can learn so much.
And you can you mention your handle on Twitter is?
It's actually Subi? No. So my username is Subi, but my Twitter handle is Little Miss Ileo.
Oh, this is true.
Yeah. Yeah.
I just know you as Subi.
S-U-E-B.
For Sue Blackwell. What is that? What is Little Miss Ileo? Oh, Ileostomy.
Yeah. I don't know.
I just got it.
Yeah. I joined Twitter like so long ago. I think it must have seemed like a good idea at the time. You know, when you've had a Twitter handle for so long, it's like, there's no point in trying to change it now.
Yeah.
At least it says Subi. It doesn't say anything else.
All right. Very good. All right. So I'll post that on everyone's asking about you. So I'll post it on Facebook and Instagram as well, so that they can follow you. That's fabulous. Thank you so much. That's been a great hour.
Oh, pleasure. Thank you for having me.
All right. Well, that ends it for us, everyone. Thank you for joining me on HerniaTalk Live. Sue Blackwell has been amazing. Thank you for your time all the way from Liverpool, England. And I come to you from Beverly Hills, California. Thanks, everyone. See you not next week, but the following week. I will be live tweeting from a conference again next week. So follow me on Twitter at HerniaDoc. And then this session will be available to you with all other sessions. I think we're up to 94 on our number of sessions. So follow me on YouTube and watch all of these and more. Thank you. And thanks again for your time, Sue. I appreciate it very much. Bye.